who knows if anybody's even going to be there, but.
Then I'll just have I have a desk with a Cal bear and a UCLA bear, so they're my audience right now.
Oh, well, I have Lucy Van Pelt back there. So, and a monkey here, so.
Great audience. Well, now my Wi-Fi is super slow.
Shelley, I'm not seeing it yet. Are you seeing it on Facebook?
Well, it said live. Good evening. This is Shelley Rodriguez with the California Academy of Family Physicians. Thrilled to have you join us this evening for CAFP Community Conversations. We started these conversations about a month ago when we all started sheltering in place as a way for family physicians and family members to come together, chat about what's happening, share latest information on COVID-19 or on other topics that are important to family physicians. These are your conversations, so you need to let us know what you would like to hear in each week's segment. Tonight, I am thrilled to say that we have two wonderful speakers who will be talking about ACEs, the Adverse Childhood Experiences, and the parallel track on resilience. Quite timely with COVID-19 and some of the adverse experiences people are having because of the anxiety and the like for COVID. Couple of ground rules as we get started. We are live streaming on CFP's Facebook page, so please remember others will hear or read your comments. If you have a question, please type them in the Facebook comment section. Josh Lunsford is going to be watching that box, and he's going to be triaging the questions to our panelists and moderator, and we'll get those answered for you. We are pleased to offer one AAFP prescribed credit for the live activity. We will put the link, this link that's here on the screen, in the Facebook chat so that you have it and you can click on it to claim your credit. We're going to do our best tonight to get as many of your questions and comments answered as possible. We apologize in advance if we don't get to all of them. We do save the chat box and we try to respond to you during the week. This is also recorded, so you can come back during the week and watch it or share it with colleagues and get questions answered that way as well. We do conflict of interest because this is a CME activity, and none of our faculty or people who have influence on content tonight have any financial relationships to disclose. We have two people on the line with us tonight, and we're thrilled to have them. Adia Scrubb, MD, MPP, is a third-year resident at John Muir residency program. She is an inaugural fellow of the Susan Hoagland CAE Health Policy Fellowship, and she's going to be presenting her fellowship project. And Brent will introduce her in a little more depth in a second. Brent Sugimoto, MD, MPH, Fellow of the AAFP, is also with us this evening. Brent is the founder and chief medical officer of Direct Health, and prior to that was with Permanente Medical Group in Oakland. He's the editor of California Family Physician Magazine, and he's the new physician director on the AFP Board of Directors. Our objectives for this evening really are to define ACEs, their prevalence, the impacts on health and underlying medical conditions, discuss the role of resilience, and then walk through a case-based use of a resilience matrix for ACEs. We also want to announce that today, launching, and you should have received an email, is our monograph, We Are Not Our Numbers, Understanding Adverse Childhood Experiences, Scores for Physicians and Their Practice Teams. This is available to all California physicians and practice team members. It carries 4 CME credits, either AMA, PRA, Category 1, AFP prescribed, and we have nursing credit for it. Free and it does meet the criteria for the Medi-Cal ACEs screening payment attestation. It'll be on our website. We'll be sending out a link and to the issue and to the website to all of our members this week. With that, I would like to let Brent introduce Adia and get on with her presentation. Adia, I'm going to make you the host so that you can run your slides.
All right. I'm going to share my screen here.
Well, good evening, everyone. Thanks so much for joining us on your Sunday for our Wellness Weekend conversation here. I am extremely pleased to introduce Dr. Adia Scrubb, who is a Susan Hoagland Health Policy Fellow, and she is an inaugural fellow, one of our first of 2 fellows for this year. This Susan Hoagland Fellowship identifies and supports promising medical students and family medicine residents committed to family medicine advocacy. And it's endowed by the CAFP Foundation to foster generations of family physicians from a wide variety of backgrounds and institutions whose leadership will inform and influence policy in California for decades to come. And I think that definitely describes Dr. Scrubb, who I believe, will be a leader who will influence health policy in California for decades to come. Dr. Scrubb received her Doctor of Medicine from the David Geffen School of Medicine and was part of the Prime program at UCLA. She also received her Master of Public Policy there at the Luskin School of Public Affairs. She is also a Cal grad. Yeah, go Bears.
Bears.
Where she reached her Bachelor of Arts degree from UC Berkeley in Comparative Literature. Dr. Scrubb has I guess a pattern of a lot of firsts. So besides being the inaugural fellow of the Susan Hoagland Fellowship, she was also one of the inaugural residents of the John Muir Family Medicine Residency, and helped set that residency on a good path to helping to build our workforce in California. Besides that, Dr. Scrubb has also been a representative for the CFP on the California Surgeon General's Trauma-Informed Primary Care Advisory Group. And I am proud to say that she has also been an author on the CAFP monograph on adverse childhood experiences called We Are Not Our Numbers. Definitely go check it out. It is a good read. Today, Dr. Scrubb is going to be talking about the work that she did as part of her fellowship about ACEs and screening. This is extremely timely, as Shelley said, given what's going on with COVID and the increase in trauma that we're expecting, unfortunately, a lot of our patients to experience. And Adia's effort is part of, I think, a groundbreaking effort led by our California Surgeon General to reduce the impact of ACEs on Californians by half within a generation. This is something that I think will be groundbreaking for not just California, but for our nation. And Adia's contribution to this work is substantial. And so without further ado, I'm extremely pleased to present to you Dr. Adia Scrubb.
Thank you so much, Brent. And I'm going to just go ahead and dive in and get started. It's a very flattering intro. All right, let me share my screen here. All right, let's get situated here. All right, so thank you everyone for joining us this evening. I am Adia Scrubb. I am a third-year family medicine resident, and I am one of 2 2019 CAFP Susan Hoagland Health Policy Fellows. So tonight I'm here to present my fellowship project around the subject of adverse childhood events and any connection and association with resilience. So my project is entitled, I Am Not My ACEs Score, Screening for Resilience in the Setting of Adverse Childhood Experiences. And so what I hope to address or answer are these few questions here in this presentation. One being, what are adverse childhood experiences? What is resilience? And why are they important? So of course, first let's start with some history and background regarding adverse childhood experiences. Adverse childhood experiences, also known as ACEs, has come to the forefront more recently due to the appointment of Nadine Burke, who is a pediatrician. She was appointed the Surgeon General of California in 2019. It has been her legacy and part of her campaign to promote the use of ACEs screening in primary care settings. With that, she started the acesaware.org website, and this was launched as a training website for practitioners so that those who are who complete the training and they then become certified, they will, beginning on July 1st, they will be able to receive payments from Medi-Cal for having done the screening. There are two surveys that are being used. One is the ACEs survey, which is for adults. That is a 10-question survey. And the second is for pediatric patients or anyone under the age of 18. That is called the PEARLS survey. That is also known as the Pediatric ACEs and Related Life Events Screener. And that is a questionnaire that is given to the caregiver to be filled out by the caregiver on the child's behalf. So adverse childhood experiences, actually this came to light by who made it possible is Dr. Felitti. And with the journal article that he published, it's called Relationships of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Deaths in Adults, the Adverse Childhood Experiences Study. And this was actually conducted in San Diego at Kaiser Permanente through surveys that were mailed to the patients over 2 waves of 2 kind of separate time periods, over which they were able to collect a total of 17,000 survey responses. Of those survey responses, 79% were white, 43% were college graduates, 52% were women, and the average age of the respondent was 56. Basically, the survey questionnaire was sent out to ask specifically about incidents of childhood abuse or household dysfunction that you experienced while growing up. And they created 10 categories, including psychological abuse, physical abuse, sexual abuse, emotional or physical neglect, mental illness or suicide, violence against the mother, living with substance use or abuse, and then criminal behavior in the home. So the answers to the survey that each of the individuals took created an ACEs score, and that is a score that ranges from 0 to 10. And with this article was particularly a groundbreaking because subsequent research helped us learn that, for instance, 61% of adults had at least one ACE. And this research was also continued with the CDC, and the CDC, of course, you know, they have pointed out that 1 in 6 adults have experienced 4 or more types of ACEs. And I've highlighted the number 4 because in the continued adverse childhood experiences research, individuals with a score of 4 or more are at an increased, at a higher risk of developing poor health outcomes as an adult. And the CDC notes that individuals with a score of 4 or more have a higher risk of poor health outcomes, and that females and several racial ethnic minority groups are at greater risk for experiencing 4 or more ACEs. And at least 5 of the top 10 leading causes of death are associated with ACEs. And part of the Surgeon General's campaign is that we can prevent ACEs and it can reduce the number of adults with depression by 44%. So the key concept behind adverse childhood experiences is actually this concept of toxic stress. And toxic stress is a prolonged response to a negative stimulus that can promote maladaptive physiological and psychological changes. This is primarily, along with other stress hormones, perpetuated by elevated cortisol. This can result in memory loss, learning disabilities, poor decision-making, dysregulated stress, and immune responses in children. And as they grow up, these levels or these developmental issues and dysregulation can result in chronic health conditions such as cardiovascular disease, obesity, lung disease. It can result in substance use such as alcohol or drug use, including poor mental health, depression, PTSD, can lead to high-risk behaviors, including early sexual behavior, unplanned pregnancy, early pregnancy, smoking, and also violence, including intimate partner violence or sexual violence. So in taking all of that in, let's meet a patient. So let's meet Carmen. Carmen is a 20-year-old female who came to her primary care office to establish care. She was accompanied by her boyfriend's mother. She indicated on her ACEs questionnaire that she experienced an episode of sexual assault. The assault took place about 2 years prior while out on a date. She also indicated that she has a strained relationship with her mother, who was emotionally abusive and negligent when she was younger. Her mother abandoned her, and this led to a brief past history of substance use as a teenager. Additional screening with the GAD-7 reveals a score of 7, indicating mild anxiety, which Carmen attributes to triggers of memories of the assault. So in filling out the ACEs questionnaire, because she is over the age of 18, she has an ACEs score of 5. And as a primary care provider, Carmen represents quite a few of the patients who come into my office. And I'm always quite stunned how so many of them have made it through a lot of life challenges, which has led me to kind of question whether or not the ACEs score really predetermines you to some of these adverse outcomes. There has to be something that is helping some of these individuals escape the supposed destiny of having a high ACEs score. So does your ACEs score determine your fate? So my rationale in approaching this project is that there are adults with high ACEs scores who do not develop poor health outcomes. This suggests the presence of what is coined resilience, or protective factors that counteract the dysregulating effects of ACEs and promotes recovery from prolonged stress or adversity. So putting 2 and 2 together, screening for resilience along with ACEs may provide practitioners with a balanced perspective that can lead to improved trauma-informed care and treatment planning. So in creating a hypothesis or a problem statement, in looking at what is being offered to our patients in the context of ACEs, resilience screening is not included in the PEARLS or ACEs questionnaires. This might create an imbalanced assessment of a patient's healthcare needs. There's currently no guidance on how to screen for resilience and no consensus on how to measure resilience. So I have to pose the question, if we were to somehow come up with an additional screening for resilience, which additional screening questions may help a clinician screen for resilience? Okay, so let's just back up for a second. What exactly is resilience? So resilience, according to the research literature, is very loosely termed as adaptation in the face of adversity with a return to baseline, or more simply, the ability to recover from stress. Keep in mind that according to all of the resilience literature out there, there is no gold standard of measurement or definition, and there is a lack of true consensus in the research literature. But what agreement there is among the research literature is that resilience develops over time, and it can develop from childhood and through adolescence, and that it does mitigate the effects of adverse childhood events. in the literature, there have been two trends. The first trend is defining or measuring resilience as individual personality traits or characteristics. And the second trend is measuring whether or not individuals have achieved certain competencies or levels of functioning despite the adversity. So I wanted to take a look briefly at what has been used to measure resilience. And there are, I pulled in a handful of resilience scales that have been used in the past to measure resilience. First, starting with the Connor-Davidson Resilience Scale. It's a 25 question questionnaire, and they define resilience as personal qualities or characteristics. And the questions on their survey include, I am in control of my life. I am not easily discouraged by failure. The next resilience scale that has been used in research is the resilience scale. This is another 25 question questionnaire, and resilience is defined as equanimity, perseverance, self-reliance, meaningfulness, and existential aloneness. And these questions on the survey include, I am friends with myself, and I am determined. Another resilience scale is the resilience scale for adults. It is a 37 question questionnaire, and they define resilience as an exposure to protective resources within themselves or the environment. And this project evaluated personal competence, family coherence, social support, and personal structure. And their survey included questions such as, believing in myself helps me to overcome difficult times, or I am pleased with myself. The next resilience survey scale is actually developed more with clinicians more in mind, and this is the Devereux Adult Resilience Survey. It is a 23 question questionnaire, and they define resilience around a combination of relationships, internal beliefs, initiative, and self-control. And their questions include, I have good friends who support me, and I have a mentor or someone who shows me the way. The California Healthy Kids Survey, particularly the Resilience in Youth Development module, has a series of questions to evaluate high school and middle school students who are developing resilience within the school setting. Theirs is a 47 question questionnaire and evaluates support in school, family, community, and peers. And their questions include, I stand up for myself without putting others down, or at home, I help make decisions with my family. So these were just a few of the more established resiliency scales, but I found that the existing scales may not be suitable to use to screen for resilience in the setting of ACEs. For instance, they measure different variables and characteristics. They are very long questionnaires, anywhere from 25 to 37 questions, and they are not created, with the exception of one, for use as a primary care clinical screening tool. And most of them are not specific to ACEs, and many do not assess the relationship with the external environment. Many of the resilience scales that were created earlier were more kind of subjective, introspective questions that were actually tested primarily in as a progressive type of questionnaire as someone is going through a health illness, more of a prospective type of check for resilience as opposed to a retrospective like the ACEs. So then that leaves me with, how do we screen for resilience? And so I'm going to quickly go through a whirlwind of what was going through my head. So first, one of the bigger problems in trying to sort through the resilience literature is that there is no consensus on a definition. So to begin with, even thinking about the types of questions that we want to use to screen for resilience, we have to redefine or make up our own definition. So I went ahead and I took the current definition, which is the ability to recover from stress, and I mixed in a little bit of the concept of toxic stress and ACEs. And that helped me formulate a new definition for resilience, being economic resources and social supports that facilitate recovery from prolonged stress. And the goal in moving forward with our new definition is to create questions that supplement the ACEs and PEARLS questionnaire to elicit features of resilience in order to construct a more balanced assessment of the patient and their risk for poor health outcomes in the future. The objectives have to be that the screening must be brief, which kind of leaves us with adding maybe 1 or 2 questions. The questions must be relevant to ACEs and applied to both children and adults. You have to be able to deliver the questions as part of the self-administered ACEs questionnaire. And ideally, these would be questions that are not included on other screening tools that will likely be given to the patient again. The key thing is that the method that we're going to be employing is what's called a weighted decision matrix. And this is an analysis tool that evaluates several options or scenarios with weighted criteria. And this helps us to produce a score for each option. And ideally, the option with the highest score is the best option. So I decided to start off with 3 criteria listed here. So I started off with competency. The literature, I chose this criteria because the literature supports that, of course, stable housing, education, stable income, and the ability to retain employment are positive indicators of stable adult functioning. And so I wanted to include that as a criteria. And my second criteria is social support. The research has been overwhelming, has the overwhelming message that support from a family member or friends, is critical to helping individuals develop resilience. More specifically in a trusted adult relationship, and more specifically a parent, but we all know that those situations are not always possible. And so any relationship really from an adult, or even if you are already an adult, a peer who's also an adult, a secure, safe relationship is critical to building resilience. So I included that as a criteria. My last criteria is self-regulation. And this is a term that helps me directly address the concept of toxic stress. If you are experiencing a prolonged amount of stress, then it only makes sense to include a question that screens for individuals who have activities that counteract stress. And this can include therapies, access to mental health resources. This can include structured activities such as sports. This can include just general exercise, or even group activities such as cultural activities or religious activities. What you've noticed below, and right here in this last column here, is the rating. And this is based on the number of sub-criteria here. And so each of these bullets here are sub-criteria of the question. And a question that includes let's say we make up a question and the question includes a question about competency. The more of these sub-criteria that are included in the actual question, in theory, would make the question more sensitive, or make the question so that the patient is more likely to respond yes. And so the more competencies that are included in the question, the higher the rank score that criteria receives. The same thing for social support. If a question is going to screen for social support, if you include parents, mentors, teachers, friends, relatives, that makes it more likely that the patient will respond yes to the question, and they will have a higher rank score for that criteria. All right. So I decided to try to give it a go, and I made up several sets of questions. And these are our question options. Mainly what I am trying to sort for, or hopefully trying to identify, is which 2 criteria are the best, or perhaps the most efficient at screening for resilience if we really only have an option of adding, say, 2 more questions to the PEARLS or the ACEs screening. So option 1 is a question that elicits social support and competency. For instance, do you have access to a friend or relative for support? And the second question, have you had stable housing and consistent income for the last 6 months? Option 2 is a question designed to elicit self-regulation and social support. Do you engage in hobbies or cultural religious activities? Do you have a parent, mentor, or friend that you trust and can ask for help? Option 3 is a question that includes self-regulation and competency. Do you know how to find exercise or therapy resources? Do you have difficulties with attending class regularly or maintaining employment? And what I wanted to point out is that some of these questions will have different rank scores. For instance, this question has 1, 2, 3 of our sub-criteria, so it will receive a rank score of 3. This question, which is also a social support question, actually only specifically asks about 1 and 2. So this question, although it's also a social support question, will receive a rank of 2. So when we jumble this all up into a giant weighted decision matrix here, what we have are options lined up, option 1, 2, and 3. What's new in this weighted decision matrix are our criteria, but they are weighted. Social support is weighted at 50% because, as I've stated before, research, although it not be entirely unified, still overwhelmingly supports social support as a very critical factor to developing resilience. So I felt that it was very important that one of our screening questions includes social support. I rated competencies at 20% because there hasn't been a strong association with education level and income with resilience. And that may just because there's a lack of literature. And then I rated self-regulation as 30% because the literature does also support healthy lifestyle and again, access to structure to help an individual self-regulate and avoid maladaptive behaviors when going through toxic stress. So then we line up our ranking scores or our rating scores with our weight, and then we get a score for each of the criteria included in our options and our question options. So, and actually I wanted to point out here is the status quo, which is basically where we are right now. The ACEs and the PEARLS surveys do not include any questions for resilience, and therefore they score 0, which is not desirable. So the best option, it appears here, is option 2. With the increased weighting of social support and the self-regulation, it wins out here as having the highest score compared to option 1 with 1.9 and option 3 with just 1. These numbers in and of themselves don't mean anything, but it just means that this is the highest scoring option according to our weighted criteria here. So let's revisit our original question. Which additional screening questions may help a clinician screen for resilience? And you may have guessed it, it's option 2. So supplemental questions that screen for resilience should include a question about social support and self-regulation. And my further recommendations after going through this process is that I would like to urge the community to create a standardized definition of resilience applicable to evaluating ACEs. And I would also like to encourage that we evaluate resilience through objective, measurable criteria and move away from subjective, introspective questions about the person's own opinion of their resilience. And I also would like to recommend that we use these resilience questions to screen and customize treatment around any strengths or supports that the patient may have. So let's revisit our patient, Carmen. After filling out the ACEs questionnaire, Carmen answers the following resilience screening questions. Do you have a parent, mentor, or friend that you trust and can ask for help? This is the social support question. She answers yes. She stated that she has received tremendous support from her current boyfriend and his mother. She currently lives with them and feels very safe, secured, and loved. This has given her the opportunity to think about returning to school and getting a job. The second question, do you know how to find exercise or therapy resources? This is a self-regulation question. Carmen answers no. She states that she does not exercise regularly. She never received counseling or therapy after the assault, but is definitely interested in therapy to help with the triggers of the memories of the assault. Carmen received a warm handoff and she was connected to a therapist. After multiple therapy sessions targeted at addressing anxiety and post-traumatic stress disorder, Carmen was able to process the events of the sexual assault and her strained relationship with her mother. In follow-up office visits, Carmen reveals that she has been able to secure a job, return to school, and also move into her own apartment. She also learned to participate in meditation to manage her anxiety, which has significantly improved. Despite an ACEs score of 5, the stability of a nurturing relationship provided a foundation for Carmen to begin to heal and to access appropriate mental health resources. A new medical home, mental health services, and practicing stress reduction have all contributed to helping Carmen reduce her future risk of poor health outcomes. So let's not be quick to label Carmen only as a 5. What she has around her right now is supporting her to move past being a score of 5. And she is well on her way to recovery. So my conclusions are that your ACEs score do not define your future health outcomes. There are protective factors for children that mitigate the effects of toxic stress. There are supportive factors that help with treatment and recovery for adults. Screening for social support and methods of self-regulation may help a practitioner formulate a more customized treatment plan utilizing the positive resources that a patient has access to. Further collaboration, research, and consensus is definitely needed on the subject of resilience in relationship to ACEs. And with that, I would like to end my presentation this evening. Here is a boring page of references, and I would like to say thank you to the California Academy of Family Physicians for selecting me to be your first Susan Hoagland Health Policy Fellow. And I had the opportunity of a lifetime, and it was quite a whirlwind year. And you can also note that I was able to meet with the Surgeon General and we talked about ACEs and it was awesome. And I'd like to shout out my co-fellow, Jessica Farmer, and she will be coming up next. And to all of those of you out there, Dr. Scrubb says, stay safe and healthy, and don't forget to wash your hands. Thank you.
Thank you, Adia. That was terrific. I learned so much. Brand, I'm going to turn it over to you. I saw you busily taking some notes, and I think you may have a couple of follow-up questions based on some of the work you've done on ACEs, and particularly with special populations in ACEs. Those of you who are on Facebook, please type your questions in the box there, and we will get those over to Brent and Adia. Thanks so much. Brent, it's all yours.
Thank you very much, Shelley. And Adia, thank you very much for that wonderful presentation. Shelley was right. I was busy taking notes because there was actually a lot of great information in there. And everyone who's watching today, I do hope that you do send in your questions because we would really like this to be a conversation. Hoping that we can talk about some very important ideas that Adia brought up today. So Adia, I guess one thing I want to start out with was, why did you decide to pick ACEs and resilience as a focus of your fellowship year?
The long story is that I actually, before even going to medical school, I was a board member of a nonprofit for adolescents who were first-time juvenile offenders, and our program was actually a diversion program for them. And I had anecdotally, just being in the environment and learning about the students in the program, very much saw how these individuals, you know, blossomed despite having a lot of adversity. A lot of them were living with alternate caretakers, grandparents, or aunts. And at that point, they were already experiencing they're dipping their toe into criminal behavior and high-risk behaviors. But this program was able to intervene at that point. And so I know I kind of have a soft spot for not setting people's destinies with their previous behavior. And so, and I think as a family medicine physician, it's really no surprise to us as individuals who get to see the continuum of life, literally from preconception until death, that that what happens to you as someone who is young then results in some type of outcome when you're older. And it is Dr. Burke Harris's goal is to definitely ramp up the prevention efforts so that we can eradicate some of this.
Awesome. Yeah, you know, when you think about ACEs, right, there are very few things that are further upstream from that, especially when you think about all the possible health outcomes that can result from having a high ACE score, right?
Yeah.
But, you know, you also, I think, argued very convincingly that we shouldn't just consider the ACE score. Yet the current initiative is basically to just screen people for their ACEs. Currently, we do not have an instrument for screening for resilience. What do you think are the potential harms of screening everyone for ACEs?
I think kind of the pushback that has always existed, even when the first article came out closer to 1998, is what do we do with the information? I think part of the difficulty really, it's not so much the danger of well, what exists is that, you know, we could potentially re-traumatize the individual by pulling up this information. But we can also find information from the individual that will allow us to help them. The catch-22 is, what do we do with the score? What does it exactly mean? And if you're in a rural community, you may not have direct access to a lot of the resources that, say, someone in an urban area. And especially dealing with the Medi-Cal population, they may or may not have a lot of resource immediately available to them. So it kind of, again, puts the practitioner in the middle of, you know, having so much more information now, but then is it a failure on our part if we can't get them to these needed services?
Right. And I mean, I think that's a really important thing, right? To me, I think maybe an analogy, something like HIV in the early days, right? When you didn't have any sort of treatment, that you were screening people and people found out that they were HIV positive, and you both had this life-altering, life-threatening diagnosis. But there are also significant social harms that could come from that screening, right?
Yeah, so kind of the fear in all of this, or one of my concerns, is that we're now going to essentially label people as numbers. And the research regarding ACEs is associated with a lot of literature that supports very, very high risk with the increasing number. And so we have to, as practitioners, be careful not to stigmatize our patients as a number, seeing a number, whether it's a 5, 6, 7, or 8, and then and being overbearing and trying to provide treatment and treating the number, as opposed to treating the patient. We want to treat the patient, and I like to think that as family medicine, we're good at that, treating the whole patient.
Exactly. And I think, you know, I have my own opinions. You know, you and I have both been participated in Dr. Burke Harris's Trauma-Informed Primary Care Advisory Group. And for people who have not been there, Dr. Burke Harris has assembled all stakeholders who who should be involved in ACEs screening. And so this includes everyone from pediatricians, obstetricians, health systems, internal medicine, and of course, many others, and family physicians. Adia, what was your takeaway being in a group like that about what is family medicine's role in this initiative of Dr. Burke Harris's?
So family medicine's role, of course, is to be there, be present. The biggest takeaway actually was that we have kind of like a very unique lens where we can go across specialties, and it's also part of our specialty is to know how to coordinate care. And so being a part of potential situations where you need to bring in OB, or when you need to bring in internal medicine or even psychiatry, I think that's going to be our strong suit in treating patients with ACEs scores. And we're also, as family medicine providers, in a unique situation where we have entire patients' families on our panel. Sometimes we are the family, literally the family physician, and it puts us in the middle. If we are having to treat a child with high ACEs score, or having to treat the parent for high ACEs scores. So that was kind of the takeaway that I got, was that we have a very unique role to fulfill, and that it should be reflected in the ACEs screening. And I think that was what I was trying to bring to light in discussing resilience, as that as a comprehensive practitioner, I can see both ends. I can see the wellness aspect of a patient, and I can also see the illness aspect.
I think that's exactly right. And I think from our perspective of not living in the same silos that I think a lot of the other specialties do, seeing the whole spectrum of the family, right, is very important. And it makes this approach to the problem differently. But I think it also presents an opportunity as well for our patients, because it's not just being put in the middle, right? Like you said, which is true, but there's this concept of, right, the intergenerational transmission of ACEs.
Right.
And, you know, there's a very strong correlation that if you're a parent, your child is going to have similar ACE exposure as you do, right? Mm-hmm. And if we're treating both the child and the parent, we have an opportunity there.
And we also have the luxury of treating the parent as a preventative measure to not having, the child exposed to the ACEs. And so, of course, that's why social support is important, not only for the child and having a stable adult relationship, but it's important for the parent to ensure that they're getting the help that they need so that they can be present for the child and not subject them to toxic stress.
Well, I want to let you know that there's a string of just compliments coming to you for your presentation. A lot of excellent and nice work. Dr. Walt Mills, our president, is saying one more step in moving our FP revolution forward as biopsychosocial specialists, improving our toolkit to care for our large vulnerable population differently and better. And a comment from Dr. Erica Rashan-Ravan from Sacramento, from our new chapter, Sacramento Davis, or Yolo County, Sacramento Valley, I think is their new name. Erica, you can correct me about the actual name, but she had a comment. She said, "Thank you, Adia, that was great. I love your focus on resilience to distinguish from you're doomed with your ACEs. Thank you very much for all your work on this." Dr. Rashan Ravan will also be presenting on the Surgeon General's webinar on this week on April 29th at noon. And so anyone who's looking forward to learning more about this will be a great opportunity to, and possibly maybe staff at CAFP can post a link for this so that our viewers today can find that. Any comments about Dr. Rashan Ravan's comment on your presentation about your being doomed with your ACEs?
I mean, that's what we're trying, that's what I'm hoping to perpetuate, that you're not doomed by your ACEs score. and that you don't just give in to having a score of 6 and being labeled a 6. And even for patients too, you know, you should advocate for yourself and don't let someone treat you into a box treat you according to your number. And there are even physicians out there with very high ACEs score, and they have gone above and beyond what anyone may have expected them to have gone past if they had their ACEs score checked when they were, say, 20, 21. You know, it doesn't necessarily mean that you are going to end up a depressed alcoholic.
This is actually, I think it's a good point, right? And you think about, you know, just without ACEs, the amount of adversity that someone has to overcome to become a physician, and that the additional challenges that might be there if even just having an ACE score as well. One of the questions was, have you seen your colleagues reevaluating their own ACE score?
I think that's going to be part of the trend as things formalize this summer. I think that is my hope, that physicians will also check their own ACE score, and also not only as a way to understand, but also as a way to check your own bias. And that you know, we'll be able to then think of the individual more comprehensively, because if you know, check where you are, then you can say, well, I'm not quite what these higher risk scores are making me out to be, so I can't necessarily judge my patients that way.
In the same way. That makes absolute sense. You know, I think you've gone a long way in helping to provide more balance to ACEs screening with this resilient instrument that you're starting to develop. And even though there's still work to be done on it, do you think there are ways that family physicians now can begin to implement this in their own practice?
Oh yeah, I mean, I don't think these questions are actually too far off from our own instinct anyway, to ask, well, are you safe? Do you have a home? Do you have a place to eat? I think really that the ACEs questionnaire was meant to help prompt physicians to think more about that. And I would like to think, in a perfect world, that family physicians are primed to then follow up with those questions. I think this is really just a way to make it formal. But that I would hope to think that the ideal family physician would always check to see, you know, if this person has appropriate resources, if they're safe, where they live, even how far they are from the clinic. You want to get a sense of, are they even going to be able to show up to their appointments? Are they going to be able to afford the medications that you give them? And that should give you some insight into their income and where their income comes from. So I'm hoping that it doesn't even have to be formalized, but I hope just this presentation alone will help practitioners realize that I don't want anyone to have a number stamped on their forehead by the ACEs questionnaire, and that there are other aspects of these patients' lives that are actually giving them strength, and that may be useful in leveraging their care.
Yeah, you're reminding me actually of a patient I had who was living with HIV, a young man in his early 20s who had migrated from the South as a young gay man to find a better life out here at the age of 15, actually. And you know, he had gone through a lot of his life, and actually we ended up doing an ACEs screening, and his score was probably one of the highest I'd ever seen in my life. But focusing on his evidence of resilience in his life actually was extremely empowering. On one hand, I think he felt like, you know, right, he'd been homeless. His mom had problems with drug addiction. She'd been in and out of prison. Right, he actually had to do sex work as a minor. Right, like all these things that predict very poor outcomes. And yet this is someone who moved geographies all on his own. Right, now was able to establish his own housing, had a stable job, and pointing these things out actually was really, really important.
Mhm.
Right.
Yep.
Yep.
I don't know. Any thoughts about?
Well, I did the same thing with Carmen. Carmen is a composite of quite a few patients of mine. And that's always kind of my go-to is, once I start hearing the story, first I pick my jaw up off the floor, and then I ask them, well, are you safe? What do you have in place right now? Because that also leads to care coordination. Do I need to go grab our care coordinator right now to help you get access to, childcare resources, enrollment resources? Is language an issue? Because trying your best to help some of the outside issues are also going to help the patient comply better with their care.
Exactly. I think you're exactly right.
Thanks. One
So-
more question, I think, Brent, we have time for.
What's that?
I think we have time for one more question.
Well, I think, okay, well, let's see.
If you've got one, if you've got a burning one.
I actually do. Adia, what is next for this work? You've spent a year putting together this wonderful project, and where are you going to take it?
I have no idea. It's just gonna, in the very least, remain a little burning passion within, and the next opportunity I get to, build on my nonprofit work and to build on my family medicine background and to move my efforts in public policy forward. I think it's just going to hopefully snowball from there.
Well, you talked about ACEs scores being stamped on a forehead. Well, you definitely have stamped on your forehead, very first Susan Hoagland Fellow. So we definitely expect great things. But thank you very, very much for a wonderful presentation tonight. And I think this was really informative, very insightful. And hopefully, I think definitely are going to get our viewers interested in learning more about ACEs and how we can help our patients as family physicians.
Yeah.
So with that, I guess I want to give you the last word. Any final comments that you'd like to make to our viewers tonight?
Just thanks for joining. Remember to treat your patient as a whole human being and not just a number.
Awesome. Well, everyone, thank you for joining tonight. And please remember that as a viewer, you are eligible for live CME. And so be sure to get credit for that. Also, just a reminder of Dr. Rashan Ravan's webinar coming up this week on Wednesday, and we'll get you information about that as well. And also check out our ACEs monograph, We Are Not Our Numbers. This is different from all the other ACEs education content out there. This is focused specifically on family physicians and primary care. And so if you want something that you feel fits how you take care of your patients, this is definitely a good read. And so definitely check that out. And please be safe out there. As always, grateful for all the work that you do for your patients, especially now during COVID-19. Want to make sure that our family medicine family is safe and well. Good night, everyone.
Right. Thank you both so much for being with us and for sharing the work that you're doing. It has been a pleasure to work with some of the smartest family physicians around to put together this monograph, and I hope that you all enjoy it. We haven't fixed on next week's topic yet, so if you have a burning issue, shoot us off an email. On May 23rd, on Sunday the 23rd, our 10 top resident poster contest winners will be presenting their posters live on the 23rd. So we didn't get to do the clinical forum where they could be up on stage to do the 2 slides, 2 minutes, 2 questions, but they're going to do them live for us on Sunday the 23rd. Jessica Farmer, the other 2019 fellow, will also be using one of our Sunday nights to present her work that she's been doing on safe injection sites in California, which also have been affected by this pandemic. So again, thank you so much. Have a great week. Thank you for spending Sunday night with us. Take care. Good night.
Good night.